Hello. If y'all haven't already noticed, this week we'll start our new textbook that we'll use for the rest of the semester. So this first chapter, we'll talk all about revenue cycle management. And when I say revenue cycle, I'm talking about from when a patient checks in at a doctor's office or in a hospital until after the final payment or denial is made and all of the steps in between. So before the 1930s, people had to pay out of pocket for their health care on a fee-for-service basis. So when they're receiving care, a hospital administrator at Baylor University noticed that the average person couldn't afford to pay their medical bills, and it was becoming a problem. So they partnered with a group called Blue Cross Blue Shield. I actually think it was named something slightly different at the time, but to work together to create a plan to help people pay these bills. And this caught on really quickly across the country, and other health plans started to be created. Mostly group policies, which are offered by employers or unions. But older people and people with lower incomes that didn't have access to group policies were still struggling. So in 1965, the Social Security Act was amended to add Medicare and Medicaid to help that population. And that brings us to what we have today. But there are still a lot of challenges within the U.S. healthcare system, such as the rising cost of healthcare, the need to improve quality and safety for patients, and also the coordination of and accountability of care and services between providers and the payers. I think the first two bullets, excuse me, are self-explanatory, but the last one's kind of wordy. Basically, it's saying that the systems in place to pay providers is really complex. So it's important that the claims are accurate and show what services were actually provided and have the reasoning for those services. Remember that medical necessity to make everything flow smoothly. Okay, the Health Insurance Portability and Accountability Act, or HIPAA, is one of the most prominent laws regarding healthcare. If you've ever gone to a doctor's office or the hospital, then you've signed a HIPAA consent. So HIPAA covers a lot of stuff. A big one is that it protects your privacy as a patient. It also covers specifically how a doctor or provider can send your health information to an insurance company for payment. So healthcare providers are the doctors that send in health claims and get paid for their services, right? The health plans are the individual or group insurance plans that pay for this medical care. All right, so y'all kind of already know that. Healthcare clearinghouses are like the middleman between the providers and the health plans. They're the only HIPAA-covered entity, CE, that can check claims from the doctors to make sure there's no errors. And then they also change the format from non-standard to standard transactions and then send them to the health plans for payment. So this really helps to speed up the process and get payment faster, basically. Covered entities are healthcare organizations that are required to comply with HIPAA. So this would be any organization that electronically transmits any information protected by HIPAA. Under HIPAA, providers cannot release your PHI or protected health information to anyone other than you or your authorized representative without your written consent. Okay, there are two parts to HIPAA, the privacy rule and the security rule. We'll get into those in a little bit. The privacy rule covers the physical security and confidentiality of your PHI in all formats, so paper, electronic, oral, okay? And this is what's included in your PHI, your name, address, date of birth, names of relatives or employers, your email address, phone numbers, your account medical record and social security numbers, and your health, health plan beneficiary number. So all that's protected by HIPAA. Okay, the HIPAA privacy rule allows your PHI to be released without your consent for these things here. So I'm sure you're like, wait, you just said under HIPAA your PHI cannot be released without your consent. So how does that work? All right, the privacy rule states that these are the only times it can be released without your consent. So for treatment, so if you're seeing two different doctors, they have to be able to discuss your options to get you the best treatment, right? For payment, doctors have to be able to send some of your PHI to insurance companies to receive, payment for their services. Healthcare operations. So not operations like surgery. This is talking about doing quality assessments to make sure you're getting the best quality of care. And also to make sure there's no fraud or abuse going on. And then to ensure public health and safety. So this would be, sending immunization records to schools, or if there's a disease outbreak in the community, it has to be monitored by public health authorities to try to prevent the spread, things like that. Okay, individually identifiable health information is any information that could identify someone specifically. Now, where the privacy rule covers PHI in all formats, the security rule specifically covers anything in electronic form, referred to as ePHI. So covered entities have to have administrative, physical, and technical safeguards in place to protect ePHI. Administrative safeguards meaning making sure all staff are properly trained, all of the policies and procedures are in place and updated regularly. That talks about how to keep ePHI. Physical safeguards would be physically protecting the computers and the workstations, having security devices in place to get to certain areas, okay? And technical safeguards would make sure only the people that need to access PHI can do so. That ePHI is transmitted safely over the network, etc. Okay. Minimum necessary is another part of HIPAA that says, okay, if you have to disclose PHI to another provider for treatment, then you can only send the minimum amount of PHI necessary that they would need. Okay. The only, you don't just send the whole record, only what they need to see. The only exception would be psychotherapy notes. These have to have the patient's written authorization, okay? So I think HIPAA is most known for protecting health information, but a big part of it focuses on preventing fraud and abuse. They did this by creating the Medicare Integrity Program that looks over providers' claims and payments to find any fraud or abuse. The False Claims Act actually began during the Civil War, and it prohibits federal contractors from knowingly filing a fraudulent claim to defraud the U.S. government or get more money than they're supposed to. This led to more recent laws like the Medicare and Medicaid Patient and Program Protection Act of 1987. This law added fines that have to be paid for any Medicare or Medicaid fraud. And they're not small fines. The government does not like for you to take more than you're supposed to. Then in 1995, Operation Restore Trust was created to target healthcare providers that were committing fraud and abuse. Okay, so what is fraud and abuse? According to CMS, fraud is knowingly submitting false claims or making misrepresentations to obtain payment for which no entitlement otherwise exists. So purposefully billing for services that are more complex than what the doctor actually did, or billing for services or supplies that weren't used, or billing for appointments that the patients didn't show up for. Okay. Abuse would be any practices that directly or indirectly result in unnecessary costs to Medicare. So this would be billing for unnecessary services, excessive charges for services, or upcoding or unbundling on a claim. So unbundling would be, if two things typically go together, they're always done together, but you code them separately to get more money. Or upcoding would be, say they got this procedure done and you code for something just like a step higher than that. Okay. Okay, and you can explain the difference between fraud and abuse on your own if you'd like. All right, the revenue cycle has 3 parts. The front end of the revenue cycle is where payer negotiations take place. So this is before a patient is ever even seen by a doctor. The third party and the doctors will have these negotiations where they decide what the payment rates will be. The front end is also where appointment scheduling is done and insurance verification happens. The middle part is where care is provided. So the patient is seeing the provider, and everything that is done is being documented. When the patient checks out of the office, the charges are captured on an encounter form, and diagnoses and procedure codes are coded. And then everything is transferred to a CMS 1500 claim form and sent to a clearinghouse, which we talked about just a few slides ago, right? That's the middleman that checks the claim and changes the transaction format. And then the clearinghouse will send it to the payer. All providers are trying to submit what's called a clean claim, which just means there are no errors, they didn't leave any information out or things like that. Okay, in your book, they have examples of an encounter form here and then the CMS claim form. Okay, I know you can't really see that, but look in your e-textbook. There are figures 1.4 and 1.5, just to see, like on the, let me pull it back up, sorry. Okay. So depending on what happens for an encounter form, the doctor will check off everything that applies here. Okay, so again, look in your textbook and you'll get to see, it has like all the diagnoses, if any injections were done, lab work, any procedures in the office, things like that. The CMS 1500 claim form, you can see like at the top is mostly like social data about the patient, and then towards the bottom is where they put in the diagnoses, any dates of service, what procedures were done or supplies were used, things like that. Okay, that's the middle part. The back end part of the revenue cycle is where the claim is processed and sent to the payer. Then the provider gets their payment, which they post to accounts receivable. Or if the claim gets denied, this is where they would check it for any errors in coding or see if anything's missing and either send a corrected claim back to the health plan or file an appeal. And we'll talk about appeals actually later in the semester. So when the third party receives the claim, first they're going to make sure that the patient is actually covered by their insurance. The very next thing they're looking for is that medical necessity. That's so important. They're also checking to see, what's the patient's deductible, what's their copay and their coinsurance, so that they know how much they, the third party payer, should pay and what the patient owes. Okay, this process of comparing the claim to the patient's health plan is called claims adjudication. All right. Once the third party pays the claim, the third party payer, they will send a remittance advice along with the payment to the provider. And this is usually in batch form, meaning multiple patients will be on the same form, the same one. And it's just explaining, what was paid for each patient. At the same time, the third party will also send an explanation of benefits, or EOB, to the patient. That's doing basically the same thing. It'll have what the patient's deductible is, how much they still owe on it, or if they've met it. It'll say how much was paid to the doctor, what they owe, and if you're on your own insurance plan, then you know what I'm talking about, because you'll get this in the mail after anything is done. All right. Here's some key terms that should look familiar to you at this point. Capitation is that amount that is agreed on ahead of time that the doctor will make on a monthly or yearly basis to treat patients. And remember, with capitation, healthier patients usually make more money for a doctor because they're not having to spend as much time or resources on them. A fee schedule is the list of how much a third-party payer will pay for each service. Okay, the Health Information Management Department plays a big part in the revenue cycle. The coders are the ones that are actually looking in the patient records and assigning diagnoses and procedural codes. Then after everything's coded, the HIM department is also making sure that there's documentation in the record to support those codes. Okay, this next thing is kind of strange. You'll also learn this if you're in my healthcare law class. But as far as the medical record goes, the physical medical record, if it's paper, or the actual electronic health record is owned by the hospital or doctor's office or whatever facility it was created in. You, as the patient, own the health information in it, okay, but the doctor owns the medium that the record is contained in. So, for example, I knew a doctor, this was years ago, I knew of a doctor that had retired and closed his practice. And so this was only paper charts at the time. But he had to take all of those patient charts, those records, and store them in his garage until the date that they could be destroyed because he still owned those records. And if someone were to file a lawsuit or CMS wanted to audit the records, then he had to be able to produce them. Okay, so the doctor owns the record or the medium that the record is stored on, and the patient owns the health information. Okay, I know we touched on coding a little bit in week 1, but let's review it here. So this is where numeric and alphanumeric is just letters and numbers, codes are assigned to diseases, injuries, surgical procedures, and supplies that are used. There are 2 different sets of coding schemes that are used. Clinical classification systems are used for reimbursement, obviously, but also they use the codes to make reports related to public health and quality control. They use them to do research and for education, and also for monitoring the performance of the doctors in the hospitals. So this would be ICD-10-CM, ICD-10 PCS, and CPT. Clinical terminologies is more on the front end. So SNOMED CT is used around the world in healthcare. You can think of it as like a programming language to put clinical findings, which can include diagnoses and procedures and health outcomes, to put that stuff into electronic health record systems. So you're probably like, how is that any different from the other one? Think of this as like a universal language. SNOMED is putting that info into the EHRs, whereas ICD-10-CM or PCS is taking the information out of the EHR and assigning those codes for each patient, and then submitting that to the third-party payers. I hope that kind of makes sense because this definition here is a little bit confusing. Okay, so those are the traditional roles that HIM has played in the revenue cycle, but as technology has expanded in hospitals, there are a lot of new roles for HIM professionals like those listed here. So we're not going to go into what all of these positions do, but if you have or if one of these interests you, you can look into them more at the AHEMA career map. It's www.ahema.org/career map. So check those out if you would like. All right. Because technology is always changing, the revenue cycle is probably going to be continuously changing as well. So this will be really helpful, but could potentially create some challenges in these roles. So to try to combat those challenges, hospitals are looking to artificial intelligence in the form of robotic process automation to kind of like fill in the gaps and cut costs across the revenue cycle. So this would be for like repetitive tasks, like pre-registering patients, or prompting a patient for more information if they forgot to fill out a certain section, so that people, like the physical people that are working there, don't have to focus on these little things, and they can be used to work in areas where a robot process automation system can't do it, right? Where human resources are needed. Another technology that's being used more is predictive analytics. And they're using this to try to like forecast or predict revenue. So they can try to correct problems that would affect revenue before they even occur. Okay. And this graphic shows you the revenue cycle. So if you're a visual learner like me, then this may be helpful for you to see it this way. It is in your e-textbook, but feel free to pause the video to check it out. And that's all I have for you today. So let me know if y'all have any questions, and good luck.